Welcome to Thinking Thoracic, the podcast dedicated to exploring the advancements in thoracic surgery. Brought to you by the Society of Thoracic Surgeons. This podcast features leading thoracic surgeons discussing and debating the latest research, surgical techniques, and trends to expand your knowledge, challenge your thinking, and help you stay ahead of the curve. Whether you're a thoracic surgeon, advanced practice provider, researcher, or industry professional, Thinking Thoracic is for you. Let's get started. The Society of Thoracic Surgeons Thinking Thoracic podcast is sponsored by AstraZeneca.
Hi, everyone, and welcome to Thinking Thoracic, an STS podcast. I am one of your hosts, Erin Gillaspie, and it is my absolute pleasure to welcome you. My co-hosts, Hari, Jeff, Jane, and I are so excited to bring you guys the latest and greatest in thoracic surgery. I am so delighted this morning to be joining you with one of my amazing and fellow Canadian colleagues, John Spicer. Mon ami, bienvenue. Je suis tellement heureux que vous êtes ici aujourd'hui.
Merci, Erin. C'est un plaisir d'être là avec toi.
Promise no more French on here. You guys do not need to learn French as well as complex thoracic surgery. Dr. Spicer is a brilliant surgeon, researcher, educator. He's been an absolute leader in the field of thoracic oncology and clinical trials and played a pivotal role in the CheckMate 816 trial, which has really helped to usher in this extraordinary new era in the treatment of lung cancer. And I'm so excited that you're joining us here today.
Thanks for having me. It's an honor. I look forward to it.
I am so excited to chat CheckMate 816 with you. So let's just dive right in. I know that CheckMate 816 is sort of our OG trial, right? When it comes to immunotherapy, really in the neoadjuvant space, sort of outside of sort of these case series and maybe a little bit of sort of original experience with the CheckMate 159. But we've been talking about it for a while now. And what I've realized is that a lot of people are really still not as familiar as I would love them to be with how this trial was set up, sort of the schema of it. So if it's okay with you, let's go back to the very, very beginning and let's chat a little bit about the study design, kind of how it was made, some of the inclusion and exclusion criteria, and give everyone that really good base background. And then we can sort of add on top of it with all these incredible and exciting outcomes.
Sure. Well, I guess, you have to understand that this came out of some original phase 2 work that was led by Patrick Ford and the Hopkins group, where they showed that the 2 doses of preoperative nivolumab had a very impressive major pathological response rate and a surprisingly high pathological complete response rate, even though it's just immunotherapy. That was in the New England back in 2018, if I'm not mistaken. And they were a very forward-thinking group, and they were led by a clinician scientist, Drew Partle, who's one of the people who, he's a founding scientist in the area of immunotherapy, helped contribute to a lot of discoveries around PD-1, PD-L1 therapies. And they really understood, I think, even back then, a lot of the mechanisms behind immunotherapy and the notion that there was a certain importance to the tumor being in situ for it to for immunotherapy to have some sort of efficacy. So that's why CheckMate 816 was front-loaded for the immunotherapy, getting it before the operation, and why there was no post-operative treatment, because they really believed that that most of the effect would be obtained before surgery. And in fact, they were also believers of the potential value of CTLA-4 inhibition, so co-stimulation. And that's why the original design of CheckMate 816 was a 2-arm design comparing neoadjuvant chemotherapy to neoadjuvant ipilimumab plus nivolumab. And the regimen was 1 dose of anti-CTLA-4 of ipilimumab combined with 1 dose of nivolumab followed by 2 additional doses of nivolumab, then surgery. And subsequently, partly in due to work that was being led in Spain by Mariano Provencio and the Spanish cooperative group. Chemo nivolumab came on as a third arm, and eventually the comparator, the phase 3 comparator to neoadjuvant chemotherapy, and that was as a result of the original Nadim-1 presentation at World Lung in 2018. I think it was in Toronto. And I forget, I might have been sitting next to Harvey Pass. And when they presented a PCR rate of 60% or something, he's like, holy shit, we're done.
Yeah, it's amazing, right?
So it was really kind of taken aback by that high PCR rate, which I think we all were blown away at that time. But that was data that was obviously being generated with nivolumab as an investigator-initiated trial, and led to some protocol amendments that ultimately brought chemo to be in a head-to-head comparison. Meanwhile, there were some early reports from the internal study at Hopkins that was being in partnership, I believe, with Sloan Kettering, and I think one also at Mass General. I don't remember exactly the other partners, but they published, I think, 10 or so patients on the Ipi-Nivo regimen, where there were a number of them who did not go to surgery. There were some immune-related adverse events, and I think we were also seeing it in the CheckMate 816 patients, and so that arm was kind of kept as a phase 2 and not included in the phase 3 comparisons. Maybe unfortunately, because we can talk about that in a bit, but the long-term results are actually promising from that regimen. There are some challenges to that approach. So that's kind of where all this came from my perspective. Now, I wasn't on the design team originally. I was just a site investigator, and kind of got involved into the design later, and the discussions around the trial, because there weren't too many other surgeons on the PI team. So that was sort of how I became increasingly involved in that trial.
Yeah, and I'm so glad you were, because really, anytime we're moving a drug into that neoadjuvant setting, it's really critical that we continue to collect these key surgical outcomes, because we want to make sure that we're still performing surgery very, very safely. So let's chat a little bit about sort of the two primary arms that ended up being reported out, sort of as the key sort of flagship parts of the CheckMate 816 trial. So we have the chemotherapy arm, we have the chemotherapy nivolumab arms, and these patients are getting 3 doses of these therapies, and it's delivered at 3-week intervals. We've got a little bit of a gap, so we want about surgery, restaging, then surgery within about 7 weeks. Of the time period of finishing up that therapy. Now, one of the things that, kind of struck me is historically, we've given a lot of neoadjuvant therapy as a part of different trials, right? Thinking back as far as the INT-0139 trial, and there's always been a little bit of a debate of 3 versus 4. And I think a fact that confuses a lot of folks is, as we're getting into some of these peri-adjuvant trials, a lot of them are couched as sort of up to 4. And so most patients are getting 3 versus 4. And I know you weren't part of sort of the original team, putting this together, but any thoughts on the 3 versus 4? Are you guys mostly giving 3? Are you giving, trying to get that 4th dose in? Where are you landing on that, out of curiosity?
Um, I mean, I've learned that in oncology, what you give is what you can get.
Yeah.
And so in Quebec, we're in a relatively unique scenario where we only have CheckMate 816 approved and no perioperative regimens approved.
Okay.
It's important. I mean, the peri-op regimens and Keynote 671, in which I was also involved, kind of held the line of traditional thinking around the importance of platinum and specifically cisplatin in the early stages. The thinking behind 4 originates from all the adjuvant studies, where it's been well shown. In fact, Canadian groups led by Francis Shepard have demonstrated nicely that the total dose of platinum is strongly associated with overall survival. So the number of doses, but perhaps more importantly, the total dose delivered is quite crucial. But something you hear over and over again from the med oncs is that it's easy to get 3, it's hard to get 4. And so I think the thinking behind 3 doses in 816 was that 3, you'd probably hit your target dose in most patients. You wouldn't over tax them obliging a 4th dose. You wouldn't have deviations or missed doses because of patients not making it to the 4th. And there was, it is still kind of in that window of opportunity where you don't want to delay surgery. There's a bit of unknown about how the immunotherapy would contribute to the execution of surgery. So I think it was sort of splitting the difference, and also allowed for postoperative chemo. And there were a lot of centers who are still on that sort of perioperative design, going way back to the Roth trial of the early 90s, where the design was perioperative chemotherapy. And I forget the number, but it's probably between 20 or 30% that did receive some postoperative chemo, as is done in other diseases like esophagus and other sites where they may give more, though the evidence isn't super strong, but some oncologists, more is better. And so the protocol allowed for that.
Yeah, I actually, candidly, I'm super grateful for it, because I think your comment about you can more easily get 3 in is sort of right on the head, right? It's not uncommon that, now that a lot more of these regimens are being used very, very frequently, preoperative or perioperative regimens, it's not uncommon for me to get a call. My oncologist is planning 4, I get a call after 3. It is, I just can't get another one in. And actually having
Right.
this data, having the evidence to show that we can actually do 3 very effectively as part of this CheckMate 816 regimen, I actually think is such a gift. And so I'm actually really, really grateful for it, in so many
Yeah.
ways.
Well, I think that's come up a lot lately with this debate about perioperative, and you could talk about it on the front of chemo, but it's also, uh, valid on the front of the immuno component. In 816, as I said, the original design was ipi-nivo, no chemo. And
Yeah.
so as a site, we had to we did believe that chemo was important in stage 2 and 3 patients, very important. We had no idea what the long-term benefit, if any, would be of ipi-nivo. So and there was nothing specified in the protocol about how we should adjudicate postoperative chemo in those patients. So we made a kind of team decision, and this is some of the subtleties of protocol design and how site-specific practices can start to taint an outcome in a big way when you're not necessarily stratifying for all these factors. But we had decided that if the patient did not achieve an MPR, that we would give adjuvant chemotherapy. But that was arbitrary. But that was kind of like, okay, they had not a great response, then we should at least give them standard of care chemo. If they had a good response, presumably the outcome would be better, and so we would allow the patient not to get. It would be discussed, obviously, but the oncologist would sort of feel more comfortable not to give that postoperative chemo. This all applies in the perioperative setting where, yes, the intent is to give 4. That's what the protocol allows for, but you never know on day 0 what's going to happen after 1, 2. I mean, we had patients who burst into flames after 1 cycle, and then you have to operate on them more expeditiously. And I think that's where the perioperative regimens are important, is that they offer that flexibility to adjust the postoperative component based on what may or may not have happened in the. But a blanket application of these regimens is an error, right? I think that's where we run into to serious problems if we're not kind of making iterative decisions along the way that are informed by how things progress.
Yeah, I'm so glad you mentioned about the sort of adjuvant time period of sort of the CheckMate 816 trial, because it's really funny because you look at the sort of inclusion criteria, the eligibility criteria, it's very, very well structured, right? We've got our stage 1B to 3A, tumors greater than 4 centimeters. We're using our 7th edition. Just as a reminder to everyone, we're now at 9th edition staging. We use the 7th for this trial. We have very clear ECOG. Patients are stratified based on stage, based on PD-L1, based on gender, all sorts of different factors. We've got these preoperative regimens, very well structured. We've got our surgery within 7 weeks, and then adjuvant is discretion of the treating physicians. And so there is some variability there. We do see sort of that popping up, as we sort of read out the results of different strategies in different institutions. And it's really, really great to hear yours and that you guys are bringing together a multidisciplinary team to sort of guide that phase, because it's still, I think, a little bit in question what we should be doing, based on response.
Oh yeah, absolutely. It's like the area for which we're going to continue to struggle for a fair bit of time to make decisions. Yeah, it's we even though we don't have access to adjuvant IO here in Quebec, we have many protocols that deliver it, and we still make a point of having a tumor board discussion about it after surgery, sort of to take stock of where the patient is, and from a clinical perspective, what is our perspective on what ought to happen next. I think it's really important.
I love that. I love that. Okay, let's talk surgery, because we're both surgeons. We love surgery. We love to be in the OR.
Of course. Yeah.
So I can tell you the very first time I operated after immunotherapy, and this has been a little while now, is my first year. I'm a brand new faculty. It was a patient who'd been on immunotherapy for, I think, 2 years at that point. Radical response, single site residual disease. They want some tissue, and they're like, hey, can you go in and get this out? And as my partner and I were chiseling through cement, trying to find this nodule, we're looking at each
Mm.
other going, oh, this is going to be an interesting future.
Mhm.
And I think a lot of people had those early experiences, right? And we're operating after a lot of immunotherapy, these very dense responses, a lot of fibrosis, a lot of treatment effect. And so I think there's a little bit of fear, going into some of these trials, right? What are we going to find? So tell us a little bit about what CheckMate 816 found with regards to sort of surgical safety. What did that look like intraoperatively? How are people conducting their cases? And some of the findings that you guys had.
Yeah, so I think before going to the trial data, it's important to
Yeah.
know what the real world data shows, and there's some nice publications out of the General Thoracic Surgery database that are rather clear that receiving neoadjuvant chemo doesn't really change the postoperative complication profile as compared to upfront surgery in a stage for stage basis perspective. And I think what that says is that when you operate on stage 3, or some central stage 2s, or even a central stage 1, I mean, they can be challenging operations. Or a patient who has TB can be a very challenging operation, even for stage 1. So we do complicated surgery all the time, irrespective of preoperative treatment, and we find ways to get through it. And sometimes those things are unpredictable, right? Like we go into the OR and find cases that are much more difficult than we had anticipated, even without the confounding factor of preoperative chemo or immuno or whatever. Now, so I think that was we knew this beforehand, and as part of the reason we recruited well is we were already, or I was trying to bring the MD Anderson view, which is that if you're a high clinical stage, that you should get neoadjuvant chemo. Get that out of the way. It's less morbid, and then giving it postoperatively, and that shouldn't impair your surgical execution. So the 816 data is rather clear on that there's no increase in postoperative complications, no increase in postoperative mortalities. The surgical times were about half an hour shorter, whatever that means. There were more MIS cases done, even though in both cohorts there were more open surgeries performed, or fewer pneumonectomies. So everything was very encouraging in 816 from a surgical outcomes perspective. And I was frustrated when the first data sets came out. It's like, there's not enough detail here. Like I was like, we don't have the clinical TNM on these patients. What the hell? And then retrospectively, because these were all pharma designed trials with maybe not as much surgical input at the design phase as would have been desirable. Turns out the 816 surgical outcomes were pretty complete, in comparison, anyways, and so that's been very informative. And now we're seeing some real world series coming out that are confirming that. In fact, seeing even more patients being operated by minimally invasive techniques than what we had seen in the trials. And I think that was just us being cautious, right? Like I think myself included, when I first maybe 10 patients, I didn't even think to do them minimally invasive, but then because 80 to 90% of my front lung resections were MIS, I was like, well, why am I not trying? And then you kind of develop the skill set bit by bit to do them more and more complicated things, MIS, and to the extent where you're like, why am I putting myself and the patient through this long surgery when I could do a more straightforward open operation? So yeah, that's been kind of my pathway. I think trying to do it in alignment with the data that's been coming out, and the other trials have kind of reproduced those findings of more favorable or at least equivalent. I think these weren't studies designed to assess the impact on the surgical execution. It'd be nice to have some more prospective data on that specific question, but it didn't seem to be harmful.
Yeah.
Now, some people may say, well, oh, what about all these patients not making it to surgery? That may be harmful. And I get that. I hear that. I don't think most of us were ever seeing those patients in the surgical realm. Like those patients were going mostly to chemorads and not even being considered for surgical resection. Very hard to really know that. But we're starting to see this shift, and it would be, we're trying to collect those data. What was the impact of standard of care, neoadjuvant or perioperative therapy becoming available on the global management of clinical stage 2 and 3? Has there been a shift towards the surgical realm, or we don't fully know that, but I suspect that based on the practice of most places, a lot of these patients were never being considered, and we're seeing that. We'll see it soon out of the MDT Bridge study, which was meant to enroll borderline patients, and you'll see a lot of them went to surgery. So
I'm so glad you mentioned that, because it seems to me like that is a huge point of consternation with a lot of these trials coming out. And, if you look back at almost any neoadjuvant trial that we've done or periadjuvant trial that we've done, there's always patients that aren't going to go on to surgery. And one of the key criteria in a lot of these trials is surgeons are supposed to look at these patients up front and determine if they are resectable or unresectable. And sometimes that is actually very difficult decision making at that first upfront clinic visit, right? We don't have a cardiac workup that we sometimes need. We don't have PFTs. We may have an incomplete staging. And at the time of enrollment, there's no question there was patients that ended up in each of these trials in hindsight who were borderline resectable. And then upon reevaluation, really truly weren't surgical candidates. And so some of that 20% that we consistently see sort of across all the trials not ultimately making it to surgery are patients who really probably weren't resectable anyways. They got a therapy. And I agree with you. I think that MDT Bridge is going to be wonderful because that gives us that neoadjuvant time period to get these patients on some kind of treatment. We don't want them sitting there during a lengthy workup, getting nothing. They can get prehab. We can do things to make them the best possible surgical candidate. And then they can be sort of relegated to a local therapy, whether it's surgery or if it's radiation. And I think it's important to note that in a lot of these trials, we're not losing a huge percentage of patients to progression, right? It's not that all of these 20% of patients are progressing on therapy and we're losing them. It is patient decision. It is a small percentage of progression. It is patients who truly weren't resectable that ultimately are sort of leading to this 20%.
Yeah. I think a couple points that come to mind on this. Number one, if we believe that resection is still an important part of this disease, I hope that's the case for most of the audience, then I really believe that surgeons have to be identifying the patients primarily. But if you think about these trials, in terms of North American PIs, I think it was myself and Moish on 816 and 671. The Japanese are surgeon oncologists, so a lot of them would both treat and operate, same in China. But other than that, every single other PI is a medical oncologist. So if you're running a trial, who is screening for patients? Is it the surgeon or is it the med onc? And then if it's the med onc, and they need to get things done within a certain timeline, how many of those patients were deemed resectable via phone call or a tumor board presentation where the surgeon never meets the patient before they get the neoadjuvant? And still to this day, when I give talks in a lot of different places around the world, I shouldn't say most, but many centers aren't requiring that in-person visit with the surgeon to determine whether they think that patient is operable. And I cannot conceive of working that way. Like, I could not accept to put a patient in the OR, put a patient on this protocol without seeing them and talking to them and explaining to them what surgery entails, what the risks are, how I would plan to do it, what might happen. All these things I think are for me as their surgeon to share with them and to see if they're on board with that. This mitigates a ton of attrition, and to the point that we haven't had. We've probably put 80 or 90 patients on perioperative regimens. Not a single one has not made it to surgery. And I think it's because that has been our approach. It's the surgeon who identifies the patient. If the patient is identified by pulmonary oncologist or med onc, that's fine. But there is an in-person vetting of the operability before that patient's enrolled on a trial, and we do the same in our standard of care practice.
We do the same. And I agree. We've not seen that 20% drop off rate. And I'm a pretty aggressive surgeon. I'm happy to operate on multi-station N2. I do all
Sure.
the crazy double sleeves, triple sleeves, all of those things in our practice as part of our group. I'm sort of
Yeah.
the one that gets all of those patients shuffled over to me. And we're not seeing a big drop off, but we've also taken a really aggressive approach during that neoadjuvant phase. I get all my patients in plum rehab. I assign them exercise programs. Everybody gets
Yeah.
smoking cessation packages. We're calling them and checking in on them every week. We're seeing them
Yeah.
back after 2 cycles, making sure these patients are staying on target. So I actually think there's a lot of things, as you alluded to, that we can do to really reduce that rate of people not getting to the operating room. And I agree with you. I actually think I'm operating on more complex stage 3s than ever, actually, than I did prior to these regimens coming into play. I think we are going to be operating and using surgery as our local therapy for a lot more of these patients, which is really exciting.
hmm Yeah, and I think the sort of more modern trials that are coming out are showing that 20% is not really reproducing itself. Like even in different disease, like EGFR mutated disease, the Neodora trial shows that most of those patients are getting to surgery. I think the attrition was only like 5 to 10%, depending on whether you're the OC or OC chemo group. And so I think that surgeons are learning, teams are learning, and we're much better than what the trials have shown.
Yeah. 2 other things I want to dive into in sort of the surgical realm of things. So number one, I want to go back to a really important comment that you made about minimally invasive versus open. So especially in some of these index trials, and I sort of did the same as you, my first cases were open because historically I remembered what it was like operating after years of immunotherapy. And I sort of had braced myself for that same experience. But after 3 doses, even after 4 doses, we don't seem to see that same dense fibrosis. Now, in patients who have a complete pathologic response, yeah, you can run into a lot of fibrosis, which is usually as I'm getting through it, I'm like, yes, this is going to be a good one. But
hmm
60% of that trial, if memory serves, were done open. And some of the later trials, so our Keynote 671, the Aegean trial, maybe a smaller percentage, but there's still a good number of these cases being done open, in particular when you're doing complex reconstructions on the PA. I think one of the disservices potentially that we've done ourselves a little bit sort of in the surgical world is most people are only privy to these beautiful surgeries being shown at conferences where people are, reconstructing a PA, reconstructing a bronchus, and everyone now has this idea that that's the way that these surgeries have to be done. And one of the things that I really think is important to emphasize is that at the end of the day, the patient needs a very good surgery, a safe surgery, an effectively oncologic surgery, and a surgery that is the appropriate length of time. Being in the operating room for 12 hours as opposed to
Yeah.
3 hours is not a good investment in time for that patient, because there's a lot of morbidity of being under general anesthesia for a long period of time. And I think everybody's practice needs to be sort of gauged for experience level, comfort level, all of those things. And doing a really safe open surgery is not the wrong answer if that's what's the safest thing in your hands, right?
I couldn't have said it better. I mean, I think pride can get in the way sometimes when you're kind of obsessively trying to execute the plan that you had at the beginning of the day. Um, the 12-hour surgery is dangerous for the patient. It's in our environment in Quebec. It's bad for the 2 or 3 other patients that were also booked on that day who are now canceled, who could have had their surgery. So it creates all sorts of problems. I think the quality of life data now, it's not proof that open is fine, but it suggests that the return to baseline quality of life, the rate of return is quite comparable to MIS. We know that from the Violet trial. And so it's well, we'll see. I think they're presenting a meta-analysis of the RCTs of open versus VATS for upfront surgery at World Lung. So we'll see what they show. But at least what we know currently is that it's not particularly harmful to do in the stage 2-3 setting to do an open operation. If, as you said, you think that that's the safe, oncologically sound way to get the job done. And it seems to not be impairing quality of life in a terribly obvious way. So I've adjusted my practice not to. I kind of give myself a couple hours on a tough case, and I feel like I'm not making progress. Either there's a partner coming in to help me move the thing along, or if hopefully if they're available, and otherwise we're just going to open and get it done. But it is one of we're in that surgeons are constantly being put in a very difficult place these days. We have no good metrics of predicting PCR. You're often caught between doing an very extensive or problematic resection for the sake of getting negative margins on a patient who may have a PCR. Pneumonectomy for PCR is not a great outcome. It may be necessary sometimes, but it's a bit of a failure of our scientific understanding and clinical judgment to be able to avoid that situation. And so that's an unmet need right now. So there's good emerging data about the potential value of PET SUV reduction to help predict the likelihood of a PCR and PR. And so that can be a useful test to add to the postoperative evaluations, to add that PET, with the caveat that you may have a number of new pieces of information that are hard to interpret, like flare and that kind of thing. But we are in a tough place about making surgical decisions, uncertain about the depth of response, and we need to improve in that area.
I couldn't agree more. And actually, that's one of my favorite supplemental tables in the CheckMate 816 data, was actually looking at the radiographic response and the number of predicted PCRs versus the actual PCRs found pathologically. And it's like 1% of radiographs show a PCR
Right.
or suspected PCR, and 24% of patients have an actual PCR. And so radiographs alone, not great in predicting that. And I agree. There's no better celebration than getting to tell your patient they have a PCR, but by golly, you don't want to have to take out an entire lung to make that determination.
Yeah, so true.
Let's talk a little bit about R0 resections, because this is something that I think we don't talk enough about conferences, and it's always sort of slid into the data when it's being presented as it comes out. But to be honest, I was actually surprised. The R0 resection rates were lower than I expected them to be with some of these trials. It's anywhere from sort of 8 to 10% where we're seeing sort of these R1 resection rates. And obviously the definitions of R1 resection vary just a little bit by some of these protocols. And so historically, I think we all think about R1 as being just physical tumor present at the margin. But I think it's also important to know that we think of a positive margin also as extracapsular nodal extension that does not have additional tissue taken out around it. What do we as surgeons need to be doing to drive up that rate of R0 resection? Because we know that actually influences the outcome, in particular in patients who still have residual disease. We know that cohort is not going to do as well over time. And that's a difficult radiation plan, is positive margins after neoadjuvant. They're having to do big fields, a lot of treatment. It's not well tolerated. How do we make that better?
Yeah. Well, I think I don't have the answer. I think there's one very important piece of data is that kind of goes along with this R0 business is that now, after 816 and all the peri-op trials, the most common site of recurrence is local regional, which was absolutely not the case, obviously, before immunotherapy was brought into the preoperative setting. So it kind of leaves the onus on us as the local regional therapists to do a better job. But what does do a better job mean exactly? I think is important to know. While the data that's collected in the trials indicates that local regional failure is the most common failure, I don't have a careful and a granular understanding of what those failures are. Are they in the surgical bed? So is it an N2 node that in the 4R position that I should have taken but that I didn't take and has now recurred? Is it in the residual ipsilateral lung? Is it a contralateral lymph node that I couldn't have really gotten by my usual practice and should have been suspected based on the pathological findings and driven an adjuvant radiation plan? Or is it a pleural recurrence? Like we don't know that. And that is another unmet need that the surgical community has to use, prospective data collection to assess, like what are our local regional failures? What pre-surgical metrics do they associate with so that we can predict these things? I think all have to be doing complete nodal extirpations in these patients, and we're going to present some work at ITSOS in a few weeks on the sensitivity, specificity, accuracy of intraoperative frozen section pathological assessment, which I think we would love to see validated by other centers. But I think, my usual practice before this whole era emerged, I was not using a whole lot of intraoperative frozen section because we had to be I had to be quick in the operating room, and it was potential waste of time. And but I think there's increasing value in those intraoperative assessments to make sure that you make the most of this opportunity of being in the OR to get the right thing done, and maybe to tailor your surgery. So utilizing all the tools that we have to mitigate those local regional occurrences will have to be an area of focus in the coming years. And then also understanding where the limits of surgery are and where maybe radiation could come salvage things, whether it's in a delayed or preventative manner. We have to decide what's best. But to me, what we're not doing that the radiation oncologists are doing a very good job of is painting preoperatively our surgical field. So we should be able to, on a CT scan or a volumetric kind of way, say, this is what I'm taking out, and paint the lymph node stations and paint the lobe, and this is my intent. And then reference that to what was actually done. And there are ways we should be able to do that just as robustly as the rad oncs are doing, so that then you can say, okay, well, was this recurrence in that painted field? Did the surgeon do what they said they were going to do, and despite that still had a failure within their volume of resection? Or is it happening outside and there's nothing really more that they could have done to mitigate that? And I think this would be very, very valuable work to be done.
I agree. I love that. And I think going back to the pre-treatment scan is so critical, right? Like a lot of people focus on that post treatment scan, which is important, right? Because it's helping you to sort of, plan things, where your residual, disease is, and can you get away with a sleeve versus a pneumonectomy. But I think you have to go back to that index scan again and make sure you're identifying and targeting all of those areas where disease existed initially. And I don't think we're always doing that.
Mm-hmm.
And I acknowledge that nodes can be tough, right? Because especially with a really robust immune response, we see a huge proliferation of our CD8 lymphocytes in those tumor draining nodes. And so they can be very bright on PET. And those often are not positive nodes, right? They are active nodes that are helping your immune system to fight against this cancer, but sort of using every piece of data we have to get the best resection. I love that.
Mm-hmm.
All right, well, let's dive into some of the results of the trial. So the original and really one of the new endpoints we're using very, very frequently in sort of trials nowadays for surgical or pathologic response rates, along with EFS, and then an OS sort of comes much later down the pipelines, which has been sort of a big change for us. And a lot of our treatments are getting approved based on these sort of surrogate endpoints. Give me a little bit of your thoughts. What do you think about PCR, MPR as sort of our more standard, really emerging, highly used endpoints? Where do you land on EFS? Are you happy to work on EFS? I know there's still a lot of people out there that really want that OS data before they make practice changes.
Um, well, I think I actually like PCR better than EFS.
You do.
EFS is a little bit, there's some stuff in there that I'm not sure is really important to the patient.
Yeah.
So, for example, getting surgery. I think surgery is important, but not for everyone. And that, non-resection due to some sort of presumed progressive event is an EFS event, and it may not be relevant to that patient's long-term outcome. So you can get this, and there's a trial in ongoing with SWOG where I think they called it what was it, real world EFS or something, where
Yes.
where they're comparing upfront surgery to neoadjuvant plus surgery, and right there, like if you believe the trial data, you're giving the upfront surgery an EFS benefit of 15 to 20%, which is kind of crazy, like it may not be important to those patients to get the operation, and you stand to create a scenario where the OS outcome is inverse to the EFS outcome if it's not really necessarily an outcome that we know is linked to being alive.
Yeah.
So I think these composite endpoints are very useful, to get indications before we have to wait out the OS, but they're not necessarily a clear indication of the biological response to the treatment. And when we start to see PCRs from pure systemic therapy, at that point, I knew we were in a completely different world, because that meant, you don't have the proof of it, but it's very probable that if the PCR took place in the local regional disease bed, that all of those micromets, because most of them do, right? Stage 3, this notion that you could just operate and cure people is maybe 15 to 20%. It's true, but most people it's not. They all have micromets. So that's what we're dealing with. And that means they very likely are having complete pathological responses in their micrometastatic disease. And that's been borne out with the long-term data from 816. And it's why I think from an oncology, like big O, perspective, 816 is such an important trial, because it's as far as I know anyways, it's the only solid organ trial in the resectable stages where immunotherapy was only given preoperatively, with a very significant OS outcome that is comparable, if not superior, to all of the perioperative regimens across, breast, lung, esophagus, like all kidney, like all the other disease sites. Maybe melanoma would be the only exception where you see such a dramatic benefit. And if you look at the OS by PCR curves, it is almost entirely being driven by the PCR endpoint, which really makes you think. And so, if you have a systemic therapy that can eradicate all disease, then and you have a way of knowing who that's going to work for, man, I mean, now we're really having a big impact.
Yeah.
But
it's exciting.
Yeah. But I just want to give a shout out to the AIM High study, and kind of a brief comment on stage, because again, like one of the problems is that these, we're doing things in a very traditional way where these regimens are applied to specific stage indications, even though we know the stages blend into each other if we really look at them. And they're not isolated boxes where people don't, stage 1s aren't actually, many of them stage 4s that are unrecognized, but AIM High really demonstrated that, right? Like and it's so cool that by giving adjuvant chemo, like a 40-year-old set of drugs, that you can change the DFS outcome by like 20%, like 96% DFS at 2 or 3 years is unbelievable, right? It's incredible.
It's unbelievable.
And it's just chemo. So it really behooves us to better understand, who is micrometastatic, and fit these treatments accordingly, to deal with that disease that surgery can't otherwise deal with.
Yeah, absolutely. No, it's unbelievable. And really, I think so many people were waiting sort of with bated breath for this OS data to come out of CheckMate 816. And really with 68 months of follow-up, having 5-year survival of 65.4% for these stage 2, stage 3 patients after, in the Nivo chemo arm, and really for that to be consistent across most of the subgroups. And we'll talk a little bit more about that PCR group in just a second. But we've never ever been able to have and report survival rates like that, for this cohort of patients. And so really just an extraordinary change for us, for this group of patients. And I have to confess, when I saw the presentation and saw the data for the PCR, I was stunned. I had sticker shock. I was just like, are you kidding me? Because the 5-year overall survival for that specific cohort of patients was 95.3%. Stage 2, stage 3 patients with a PCR, 95% 5-year survival. We should be doing everything we can to drive up that PCR rate. And there's a lot of trials, NeoCOAST trial, there's more trials coming down the pipelines, really focused on trying to help continue to drive up that PCR rate for us in these patients. So just really, really, really exciting.
Yeah, so exciting, and I think the 5% or the 4.7% patients those few who did pass away did not die of cancer.
Correct.
And the one of them who did have a cancer recurrence was found to have an ALK translocation. So, which they got the wrong treatment. They got the wrong treatment. So, it really speaks to and although I know there was a paper that came out last year in JTO, sort of saying that EFS was surrogate for OS, but that PCR wasn't. But that was just a statistical lack of power to prove it. They had one trial to look at, or maybe 1.25 trials with like 2-year data on from 671 on OS. So without a doubt in my mind, and this has been true since Nadim came out and they start to show their 80+% survival rates.
Yes.
PCR is surrogate for OS when a pure systemic therapy is used. It doesn't mean the same thing when you're adding radiation on it, as far as I could tell. And that's kind of been shown to some extent in Al-Turki's trial, where yes, they had much deeper pathological responses when they did RT and immuno, but the EFS endpoints were the same on the longer term follow-up. So local regional response is great and it allows you to get complete surgery and all that, but what is critical to the survival of these patients is eradicating micrometastatic disease when it's highly probable based on stage or other metrics.
Absolutely. And that, I think, to your point about the AIM High trial, we've already incorporated the gene panels to try to help risk stratify all of our patients at our institution, actually, to offer them
That's
adjuvant
cool.
therapy. We are missing patients who are earlier stage. Most of these trials and all of the really sort of key group that were analyzed are stage 2, stage 3 patients, right? And there's no question that we have high failure rates in the earlier stage groups. And we look at, Al-Turki's other trial, the KLGB140503 trial, and we see that 35% of patients recurred during the follow-up time period. The survival at 5 years was 78% in the lobectomy group. These are tumors less than 2 centimeters. And, that's all-cause survival. Understandably, people do have other comorbid conditions, but we need that survival needs to be driven up. We need to be doing better in these early stage patients. So there's no question we're going to continue to see all of these systemic therapies creeping into the earlier and earlier stages in patients in whom it's appropriate.
Mm-hmm. Yeah, I think that surgeons whose primary sort of field of activity is in thoracic oncology, lung cancer, need to be familiar with this stuff, and not just familiar, but maybe even be capable of making decisions around them. I've really thought of myself as a custodian of local regional disease and lung cancer, and I chair our tumor board, and I really feel very strongly about weighing in some of those decisions, even though I'm not necessarily prescribing. But that's my expertise. Is this disease, and I don't think we can call ourselves experts in the treatment of lung cancer if we don't understand all these other components that we may not be directly in control of. But yeah, I think it's a very real part of the new practice.
All right, last question, and I promise I'll let you get back to what is no doubt a very, very busy day of saving lives and curing lung cancer. So we have obviously this beautiful CheckMate 816 trial. We now have OS data. We have additional peri-adjuvant trials. We've got CheckMate 77T. We've got Keynote 671. We've got AEGEAN. I think tons of people are really becoming huge believers, to your point, about really getting immunotherapy in the appropriate patients. So ALK negative, EGFR negative patients in that neoadjuvant setting when the tumor is in situ really helps to expose our immune systems to all of those, tumor antigens, really an efficacious time to deliver that treatment. But now the great debate is, what do we do after surgery? Do we need to be treating people who have a PCR with additional therapy like it's sort of prescribed in these peri-adjuvant treatments? There's a lot of people who are now saying, hey, maybe we don't need to do that based on this beautiful overall survival that we see, sort of pan out with the CheckMate 816 for our partial responders or major pathologic responders. Maybe immunotherapy is the right decision. What about our non-responders, with people who progressed on therapy? What do we need to be doing with all these patients? Should we be stratifying them based on pathologic response as our sort of indication for how we manage the adjuvant arm of treatment?
Yeah, I mean, that is the $1 million question. There's a multi-million-dollar trial to attempt to answer that. The ETOP is trying to do it in Europe. It'll take a few years before we have the data. I'm glad they're doing it because it'll help us, I think, in the long run. For us, I mean, it's an access issue, but it's also a belief thing. And part of the reason I think we don't have access is that many of the oncologists in Quebec don't necessarily believe that there is at least an OS impact to the adjuvant component. When we have a PCR, we absolutely do not want those patients to go on to postoperative immunotherapy because no one died of cancer. so
Yep.
if in 816, okay, fine, maybe it's a small subset, it's 25% of half of 358, whatever that is.
Yeah.
So maybe if we ramp up the numbers and we look at hundreds or thousands of patients who have PCR, maybe some will have recurrent events, but man, that number has to be huge for it to be justifiable. And I just don't believe that it is. So if you're not going to die of cancer, don't give something that can cause you to die of completely other set of problems: adrenal insufficiency, bad pneumonitis. So I think the risk benefit just doesn't add up there. And I haven't met anyone who's been, and I've spoken to some pretty smart people. I haven't met anyone who's delivered a convincing argument on the PCR front. On the MPR partial responders, I think the 671 data is compelling, although it's not proof, because you have to remember that the different sort of EFSs that we see in the different tiers or quartiles of percent residual volume of tumor could be because the experimental group got adjuvant therapy, but it could also be because they had a deep partial response to the neoadjuvant component. The control that you're comparing to didn't get any; they only got neoadjuvant chemo. So you can't really isolate whether it's due to the pre or post-operative. But those patients do perform better on the regimen side, which is a perioperative regimen. And on the 816 data, those patients with high percent RVT, they all die. They all have an EFS event or die within 2 years, and you don't quite see that same steepness of the curve in the 671 data. So, is a perioperative regimen maybe delaying or curing more people? It's totally possible, and I think that is a reason to consider it for sure in those partial responders. In the non-responders, in the greater than 60 or greater than 80, RVT. There, my perspective is that the patient is destined to recur, almost certainly. Hopefully not, but it's a very probable event. And so then it's a decision tree. Do you give them a treatment that has evidently not been efficacious,
Right.
and therefore potentially expose them to all the risks of those treatments, which are not, subtle, and potentially impair access to a clinical trial or a new therapy down the road because they've developed an adverse event to this already proven and effective regimen? Or do you accept the fact that this is not a great situation? You encourage the patient to use this disease-free interval, however long it might be, to get fit, to recover from their operation, and explain to them that if they recur, we understand that they've failed our existing first-line standard of care for metastatic disease, and that we will find a trial or a better regimen, maybe a CTLA-4 based regimen, or maybe we'll do extra sequencing of their tumor. Maybe we missed a rare fusion or something that would be actionable, or that wasn't picked up on the original biopsy. We reassess the plan in a very careful way to then maybe better tackle that eventual recurrence. And to me, that is the more, or we get them enrolled onto an escalation adjuvant trial. That makes sense. So there's a bunch of them that are coming online now. We have these mRNA-based neoantigen therapies. We have TROP2 ADCs. These are treatments that work across different types of biologies that could have a lot of advantages. And so those are the patients we would like to see on escalation trials or with a planned strategy down the line. But just kind of doing more of what didn't already work doesn't make a ton of sense to me.
I could not agree more. It's a hard thing to talk patients into when they're already sort of exhausted. They've been through a lot of therapy, and we're like, we're going to give you more of the same, and it didn't work.
Yeah.
I love the idea of the escalation trials, and I'm really excited about some of the trials coming down the pipelines for that, because I think it makes so much sense. And equally, there's a lot of de-escalation trials coming out because we treat patients for a long period of time, and we actually don't know what that sweet spot is. A lot of the lengths of adjuvant therapies have been chosen somewhat arbitrarily, extrapolated from some of the metastatic data, which isn't really always sort of an equal comparator. And so I'm so excited about the ctDNA, the MRD being sort of incorporated into these escalation and de-escalation trials to try to find that sweet spot for how long do we really need to treat you? How long should we accept some of these side effects to really get you the most bang for your buck with all of these therapies? And when do we need to sort of, escalate things to make sure we don't have recurrences, in particular CNS, right? Because that's really the one that's tolerated most poorly, I think.
100%. And, part of why I think 816 is so important for oncology as a whole is that it tells us that maybe some of these metastatic regimens are way overboard, that the PCR has occurred a long time ago, and that those oligomet patients that are surviving didn't really need to be on 2 or more, because a lot of people treat beyond 2 years ever, like they might have been cured a year and a half ago. And should we be exploring that more carefully? Maybe that's the value of oligometastatic consolidation is to determine whether or not that has happened and omit further systemic therapy and put the patient on observation. That 816 is really eye-opening. It tells us that these swift immune-based therapy responders may be cured years ahead of the time that we thought that they were, and what a valuable addition to our practice if we can, de-escalate some of those patients. I think a lot of oncologists will be reticent to explore that, but I think that 816 is compelling with regards to that. A quarter of the patients probably can be cured with chemoimmunotherapy in just a few doses. And
yeah, so exciting. So exciting. Well, I can't thank you enough for just such an incredible conversation today, for spending your time with me, for everything that you've done for the field. I cannot wait to see your upcoming presentations. Are there any closing thoughts, final words you would like to leave our listeners with today?
well, thank you for doing this, Erin. I think it's a really great endeavor. There's so much going on. We're at a point where where our field is growing ever bigger, ever more complicated. It's an exciting time to be a young thoracic surgeon, and I really encourage people who are in training or early in their careers, or even the later career people, to get immersed in all of these different fields. What I've benefited the most from in my career was delving into areas that were not my expertise, and seeing how they fit with or add to the area where I am more trained or expert, and that's when innovation really happens. So I think people need to keep putting themselves in those sort of uncomfortable places. That's how good things happen.
I love that. I love that. Well, thank you. Thank you again so much. This has just been so extraordinary. Wishing all of our incredible listeners a wonderful rest of the day. Thank you guys so much for joining us, for spending your time with us. Please get out there, keep spreading the word about lung cancer screening. Please keep taking extraordinary care of patients. And as always, keep smiling. Amazing listeners, thank you so much for joining us today. If you have enjoyed the conversation, please be sure to follow Thinking Thoracic on your favorite podcast platform so you never miss an episode. Your support helps us to continue to grow, improve, and to bring you the most insightful conversations. And if you have a moment, we'd love for you to leave a rating or review. It really makes a difference. Thanks for tuning in, and we'll see you next time.
Thank you for joining us on this episode of Thinking Thoracic. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.